This whole thing about one IP per 100 beds needs to go out the window. You need more IPs than one for 100 beds. So we need more people in the job. We need to have the tasks like NHSN, that kind of stuff, delegated to somebody who's not the educator, the consultant, and the researcher. So let them start there. Like I said, maybe somebody's done. You can outsource it, right? We did that at UHS. Yeah, we had a company that did. Yeah, we had a company that did the surveillance, outsourced it, and then we had a corporate epidemiologist that worked with them to oversee all that information. Yeah, you can do that to get them to be able to get out of their desks and their jobs. I just have my bias because I'm a nurse, and I know we get hit with that a lot, that the IPs that are MPHs feel like, why is it that every job wants a nurse? You find that very often that they still want to get a nurse. I'm not saying all the nurses are going to be great either. They need a lot of education as well. But at least you have that clinical aspect that they do know how to talk to patients. They are like, a doctor will talk to a doctor in a whole different level. As a nurse talks to a nurse, we have our ways. And then that's their struggle sometimes, is that maybe they're not respected, or they're like, well, they don't have any clinical background, to understand some of these things. It does come up. You can hear it in the meetings and so forth. Now, I'll be honest with you, Peter and I have gone to a couple of hospitals where in one situation, the director didn't even know where the OR was and did not tour with us. And then the other one did not tour with us. Another one that didn't, but assigned us, so they do sometimes have somebody, often a nurse, that they'll designate to the OR. So sometimes we'll get IPs from the OR who are nurses. And I think that's great, because they really do know all the sterile processing and the operating room, and they'll assign them just to be to the ORs. And that works out great, I think. And you're seeing that more and more in the big hospitals, that you'll have an IP with a specialty in surgery. But that kind of opened our eyes, that the intimidation they feel, because both of them were not nurses, and they that may be one of the reasons that it's an intimidating place to be, believe me. You got to remember, all they deal with is their eyes. I call it the third eye, right? And they shoot shots of eyes, looks at each other, and you can't see their face with the mask on. You can't see any jewelry or clothing to intimidate or, accentuate your personality. It's eyes. And it's all up here, their energy. So you have to just figure out ways, like how I did it at the Baptist and at Mass General, is I would go to the staff meeting once a quarter and give a 10-minute update on infection prevention. What did the data say? What was going on with the SSIs? And what were the projects we were working on? Were we implementing a new Tampa evidence sealed indwelling Foley system? Were we implementing a new wound care program? They would, because they're behind those closed doors and they get left out. They don't know a lot of times what happens out on the nursing unit. So I would try to be that networking interface between